Hi everyone, welcome to our module on HIV central nervous system infections. So there are four important infections of the central nervous system that happen to HIV patients. The first is cryptococcal meningitis, there's cytomegalovirus and toxoplasmosis, and then finally there's a condition called progressive multifocal leukoencephalopathy, which is caused by the JC virus. And so we'll talk about all four of these in this module today. Cryptococcus neoformans is an invasive fungus, and it exists as a yeast with a thick polysaccharide capsule that helps it to evade the immune system. This is an important virulence factor for the fungus. It's found in the soil and also in pigeon droppings, so people that come in contact with the fungus can then become infected. The main infection it causes in HIV patients is meningitis, and the way the fungus gets into the meninges is usually by being inhaled, and then it spreads from the lungs to the bloodstream and then to the central nervous system and the meninges. It can also occur in patients who don't have HIV but are immunocompromised for some other reason. So patients receiving chemotherapy can get this, and patients who are post-organ transplant and have to take immunosuppressants to prevent rejection are also at risk for cryptococcal meningitis. Patients with cryptococcus have indolent symptoms of meningitis that develop over weeks, and this makes it very different from the abrupt onset of symptoms in patients who have bacterial meningitis. And the symptoms are the typical meningitis symptoms like fever and headache. It's very important to remember that cryptococcus can raise the intracerebral pressure, and in fact, there's a risk of herniation when you do a spinal tap to make the diagnosis of cryptococcal meningitis. Anytime you think a patient may have cryptococcal meningitis, you have to do a CT or MRI of the head before you do the spinal tap. And that's because you can see dilated ventricles as evidence of increased intracerebral pressure before the spinal tap, and you want to know that. It doesn't mean you won't do the spinal tap, but you'll have a careful discussion with the patient and the family. You may have the neurosurgeon standing by. Basically, you want to know that you're dealing with high ICP before you do the tap. Treatment is with antifungal agents like amphotericin B or fluconazole, and then often these patients need to have multiple spinal taps to keep lowering the intracerebral pressure to prevent permanent brain damage. There's a couple of different ways you can make the diagnosis of cryptococcus meningitis. One is to culture the bug on something called Sabouro's agar. So this is an agar that's used to culture dermatophytes, like when you're culturing for athlete's foot, but it will also grow cryptococcus. And then there's something called the latex agglutination test that detects the polysaccharide capsular antigen. Basically, you mix the cerebrospinal fluid with latex beads, and the latex beads will agglutinate or stick together if cryptococcus is present. And then finally, there's something called soap bubble lesions on MRI, which are very rare, but if you see these, they strongly suggest cryptococcus. I'll show you a picture of that in a minute. So over here on the right is an India ink stain of a patient's CSF who has cryptococcal meningitis, and you should get used to looking at this. The India ink stain makes the polysaccharide capsule light up and give you those round halos. And then over here on the left is an MRI showing the soap bubble lesions of a patient who has cryptococcal meningitis. Cytomegalovirus can cause retinitis in HIV patients. Many of us are exposed to cytomegalovirus, but we don't get sick if our immune systems are functional. If your immune system's dysfunctional, though, the virus can infect the retina, and this will give edema and necrosis of the retina, and the symptoms patients will get are floaters and loss of vision. And this is a picture over here on the right of what it might look like on fundoscopy. People often describe it as a pizza pie in the back of the eye. And you have to have a fairly advanced case of HIV to get this, usually a low CD4 count in the range of about 50 to 100. Toxoplasma gondii is a protozoa, and primary infection with Toxoplasma usually occurs through ingestion of oocytes. The oocytes of Toxoplasma are classically found in cat feces. Felines are a reservoir for this protozoa. And when patients ingest oocytes, they become infected, but it's super high yield to know for your boards that usually the primary infection is asymptomatic and causes no symptoms. After the primary infection, however, organisms disseminate through the body, and then they insist in nucleated cells in the body, and they enter a dormant state. And so most disease of Toxoplasma in patients who have HIV comes from reactivation of this dormant stage. It's not the initial exposure that makes the HIV patient sick. It's the fact that they've been exposed, and now when their CD4 count becomes low, the Toxoplasma reactivates and leads to symptoms. The primary manifestation of Toxoplasma infection in patients with HIV is encephalitis. On imaging, the classic finding is the presence of ring-enhancing lesions. This is an example of one shown on the screen here. You can see there's this white ring around the lesion in the brain that's called a ring-enhancing lesion. And for this to happen in a patient with HIV, the CD4 count usually has to be below 100, and the treatment is with the combination antibiotic sulfadiazine pyrimethamine. Finally, we'll talk about PML, which is progressive multifocal leukoencephalopathy. It's a demyelinating disease of the CMS, somewhat similar to multiple sclerosis, and it's a reactivation of the JC virus. So many of us are exposed to the JC virus, but as long as our immune system is functioning, it doesn't cause any problem. But if your immune system becomes dysfunctional, you can get demyelination from this virus. HIV patients need a CD4 count under 200, and what they get when they have PML is a slow onset encephalopathy. So they'll have altered mental status. They also sometimes have focal neurodeficits like motor and gait problems. And you can diagnose it by finding JC virus DNA on cerebrospinal fluid exam or on a brain biopsy. And that concludes our module on central nervous infections of HIV patients.